Sangeeta, were you able to get all the studies down? Good morning, everyone, and welcome to our weekly CMR conference series hosted at ECU. Very pleased to be hearing from Dr. Sangeeta Shah and Dr. Shaimaa Fadl this morning, who are going to present a topic as part of their recurring congenital heart disease series. Just a reminder to everybody that these sessions are CME and MOC accredited, so don't forget to text the number on the screen to the code provided. And Shannon, this is not ASRT accredited today, right? This is not one of the sessions?
Correct.
Okay, perfect. All right, well, with that, I'll hand it over to Dr. Shah and Fadl. Thanks again.
All right, well, thank you, Corey. Good morning, everyone. I know it's early and congenital heart disease feels complicated, but hopefully Dr. Fadl and I will make this easy and you can use this as a reference in the future. I am going to do multimodality imaging, so bear with me. I have no disclosures. So what we're going to talk about today is how do you recognize the anomaly, specifically DTGA, detransposition of the great arteries, know its associated findings, illustrate the two types of surgical interventions, which Dr. Fadl and I have split up, and then recognize the post-op complications in these adults with a focus of cardiac MRI and how it helps. So don't fret. I know it gets really worrisome. It's 7:30 in the morning, right is left, left is right, which one, and people make it confusing, but we're going to make it simple, like I said. And I want to say that transposition, always think, no matter what kind of transposition, the aorta is the most anterior structure. Find the sternum. Whatever's behind the sternum is the aorta. The aorta always travels with the RV. This is all before correction. And the AV valves travel with the ventricles. So you don't have to rename anything. The tricuspid valve always travels with the RV. The mitral valve always travels with the LV. And what you get in detransposition is here you have a right atrium that is still connected to a right ventricle. So that is called atrioventricular concordance. And then the right ventricle is mistakenly connected to the aorta. So that is called ventricular arterial discordance. The reason the child is alive in utero is because they have mixing of blood through the PDA as well as a PFO. Another way sometimes that we think about, and this is how I started doing congenital heart disease, is you just kind of write down the segments on one side and then write down the connections and see if you can follow the blood flow. So the great veins are the SVC and IVC. Where did they, how did they connect to the atria? Then how did atria connect to the ventricles? And then how did the ventricles connect to the great arteries? And these are the connections that we talk about when putting in our report. Detransposition, as I mentioned, you have to have an ASD, PFO, or PDA to survive initially at birth. 40% of these patients have a VSD, which if I had detransposition, I think I'd want a VSD because the thought is that you can then correct your systemic ventricle. You can reroute, I won't go there right now, sorry. Anyway, 40% is associated with a VSD. 25% is associated with an RV outflow tract obstruction, 10% is associated with LV outflow tract obstruction, and 5% associated with arch obstruction. So understanding what the patient had is understanding the timeline, and I think the years are very important to recognize. So in 1948 is where they figured out how to do surgical atrial septostomy, which is to keep the baby alive. And that was revolutionary because before this period of time, if you had detransposition, as soon as your PDA closed, as soon as your PFL closed, the infant died. What happened by the 1960s is they figured out how to switch the atria, which is the mustard or Senning procedures, which I will describe. Then by 1966, they were able to do the atrial septostomy percutaneously. So if I see a patient around the 1960s, they've had 2 cardiac surgeries by then. If I see someone later, then maybe after 1960, say 1970s, 1980s, they had a percutaneous atrial septostomy. And then by 1980s, the surgeons had figured out how to do arterial switch, which Dr. Fadl will talk about. So I'm going to focus on the atrial switch. What's an atrial switch? Baffles always baffled me, to tell you the truth. But the way to really think about it is a baffle is any rerouting, wherever the rerouting is occurring. And you have the SVC, and the surgeons rerouted that through a patch, took the IVC, rerouted that through the patch, through the atrial septum, focused towards the mitral valve. So your SVC flow, your IVC flow is going to come across, go through the atrial septum, and go to the mitral valve. Posterior to this, the pulmonary veins will come behind this and go through the tricuspid valve out the aorta. So that's how you become pink. If you think about this, the kids were getting this done at a very young age, maybe 2 years old. Maybe even earlier, depending on what was going on with how well the surgeon felt comfortable, how big the baby was, etc. But if you do this at 2, and then over years, and these patients are in their 30s, 40s, your heart gets bigger. What's going to happen to all of these suture areas is what we have to think about as we think about complications. So I'm just going to go through nomenclature, so that when we talk about it, it's all the same words. This is the systemic venous baffle, which is this and this. Then you have a pulmonary venous baffle, which is behind here. You have the systemic tricuspid valve, the subpulmonic mitral valve, which is here, systemic RV, and then subpulmonary LV. As for the atria, you can name the atria, but remember the atria have just been baffled through. So you don't have to measure atrial size in these individuals because it's not a surrogate of anything. Cardiac MRI allows us with a wealth of information. I don't think I would have understood all this if I hadn't trained in congenital heart disease and done cardiac MRI together. But you're able to get, first of all, anatomy, all the connections. You're able to get ventricular function, obstruction, baffle leaks, baffle obstructions, QPQS, valvular regurgitation, and then myocardial fibrosis, as that leads to ventricular arrhythmias. So we're going to talk about cases. 36-year-old, born in 1984. I'm putting the age of when the MRI was done and the year they were born. So he has DTGA. All of my cases are going to have atrial switches, which is mustard or senning. Just to highlight, mustard was foreign material, senning was pericardial tissue. That's the main difference between the two. He presents with viral syndrome and has dyspnea and exertion and fatigue. He comes into the ER, and this is his rhythm. I'm going to tell you very easily that he has a right bundle baseline, but basically he's developed what we call IART, or reentry atrial tachycardia. We do a TEE cardiovertim and get him back into normal sinus rhythm. For some of you in the room, you look at these P waves, and basically there's not much of a P wave. They get a lot of sinus node dysfunction because those baffles are in the area of the sinus node. So this often looks like this. So let's go to his MRI. I'm going to stop sharing this, and I'm going to pull up this. Switch this over. All right, you see images? All right,
Yes.
I see. Okay. So I'm going to start with the vibe first. And the reason I'm going to start with the vibe is just to look at anatomy. And I think it's a really good way to look at orientation of everything. So as we look at this, what I'm going to point out is this is anterior, this is posterior. Your aorta is the anterior-most structure. Again, staying consistent with that. And then you see the PA. So this is right PA, left PA. This is main PA. Descending aorta, SVC. Here's your azygos. We pay a lot of attention to the azygos as we're coming for congenital heart disease. And I'm going to show you the last case where that becomes very important to see. And this is the rerouting, the cross that you're seeing of the blood flow in the atria. What I'm going to highlight is this black is the tissue of the baffles, okay? And then I'll show you better pictures in just a second. So going back. So here's his 4-chamber. This is the systemic RV, subpulmonary LV. This is the tricuspid valve. This is the mitral valve. This is your pulmonary venous baffle that is taking your pulmonary vein flow here and bringing it across towards the tricuspid valve. What you notice in this individual is there's a lot of tricuspid regurgitation. You have RV dysfunction. You have a very small and compressed subpulmonary LV. And when we see this, we're really excited because this means that the pulmonary pressures are probably normal. This is short axis, and what MRI allows us to do is do quantitative function of the RV and LV by tracing all this. When we have a D-shaped septum, this is the one time that we appreciate a D-shaped septum, and it's a positive in cardiology, is because this means that the RV pressures exceed the LV pressures. If this septum becomes straight or shifted towards the RV, that means you're developing pulmonary hypertension. It's 32. All right. When you have transposition, you have 2 great arteries in parallel. And this was a really good picture showing that. So this is your pulmonary valve going to your PA, and this is your aortic valve. So just wanted to highlight that as you're looking through it. And another picture of that is when you're doing your flows, this is a really good flow, anterior, posterior. Your aortic valve is anterior. You can actually see these beautiful coronaries coming off of it, which is what we do to confirm it's aorta if you're initially making this diagnosis. So aorta and PA, and you can measure the flows in these 2 great arteries, which becomes important for clinical decision-making. All right, and now I'm gonna show you his angio. Oh, sorry, I'm gonna stop sharing because the name appeared again. All right. So this is the angiogram on this individual. And like I said, it gives us a wealth of information on these individuals. So here's your brachiocephalic vein. Here's your SVC coming through. And I'm going to focus on that. Here's your aorta. And when you look at this, this was done when he was probably about 2 years old. And you can see how this SVC, what we call the SVC baffle, is so narrow, and it measured about 1 centimeter. And the important thing in this for us is that, one, this can cause SVC syndrome, headaches, but the other thing is often these individuals, as you saw, based on his RVEF, need devices, and they might need a pacemaker because they've developed sinus node dysfunction, or they might need an ICD. And so generally, you don't want to put something on this and cause worsening of the stenosis. So we stent it before we put a lead within there. So our general practice is to stent it. So that is our first case. I'm gonna stop sharing, go to my presentation. So this report, what did we learn from MRI? That the SVC baffle was small and it had a component of dynamic compression. As I said, it measured about 10 by 10 millimeters. The IVC baffle was unobstructed. The subpulmonary LV has increased systolic volumes with an LVEF of 45%. There is septal flattening noted, which suggests normal pulmonary pressures. The dynamic LV outflow tract obstruction, I just highlighted that. What happens is the RV gets bigger and bigger and bigger. That septum gets pushed into the LV outflow tract. It usually doesn't become significant, but you will see that, and it's typical. This individual has severe systemic tricuspid regurgitation, as well as severely dilated systemic RV with an RVEF of 27. And if you see, these are his volumes per body surface area. He does have delayed hyperenhancement at the inferior RV insertion point, and had a QPQS of 1 to 1. So I think this highlights the importance of the baffle as well as the importance of severe tricuspid regurgitation and systemic RV dysfunction. I am presenting off the wrong slide set. Sorry, I'm swapping. There you go.
Sangeeta, we don't see the slides right now.
Did you see the slides before?
No. We saw them earlier, not right now.
Sorry. Okay, now it's the. Okay. So second case, we're good now, right?
Yes, we can see it. Thanks.
So the second case is a 46-year-old born in 1977, DTGA with atrial switch, means mustard sending, with heart failure, SVT, VT, already has an ICD and has substance abuse. And so he was done on the 1.5 magnet, and he quit early on, unfortunately. So we don't have GAD. So what information can we get? So on the black bloods, I think this is very nice. Here you see the coronary, here's the aorta, here's the PA. Once again, the aorta is the most anterior structure. And then I'm going to highlight, here's the SVC. Always look for your azygos. Here is your aorta. And going through, and this is harder to appreciate, but this is your pulmonary venous baffle right here, going through. All right, 25. So I showed this image. This is your tricuspid valve. This is your systemic right ventricle, and here's your aorta. When you have transposition, you'll see this little nubbin right here, which is muscle. And the reason to identify that, sometimes we don't know what's what. Remember, with the mitral valve and the aortic valve are always contiguous. When you see this muscle bundle right here, then you got to assume that you have ventricular arterial discordance of some sort for some reason. So always important. As soon as I see this, I know this is systemic RV and this is the aorta. So I just want to highlight that. 28. So we have a big device artifact here on the subpulmonary LV. Here are your pulmonary venous baffles coming across to your tricuspid valve, and you can see systemic RV is severely depressed. And then I've highlighted 53. Once again, here's your two great arteries. And so this is your aorta, most anterior, and this is your PA. So he quit the study early on, but we still got a lot of information. I did not get a great information on his LVEF, but when we look at it, okay, hopefully this is showing my slides. Are we good?
Yes, we can see it. Thanks.
So his RV volumes, RVEF was 40%. He definitely had RVH. Once again, I said his TR wasn't as bad visually as we saw in the first patient. But what was interesting is his QPQS was significantly increased. He had a QPQS of 3.4 to 1. And so I don't know why I wrote catheter echo. I think I meant to say that this lends us to say that he needs an echo and a cardiac cath. He had a sinus of Valsalva of 42 millimeters. So we did an echo, and if you ever see a transposition with an atrial switch, always consider doing a bubble study. And what you see is here's the subpulmonary LV, have bubbles there, agitated saline, and when he Valsalvas, he shunts and fills up his whole systemic RV. So this is someone that needs a cath, probably has a baffle leak. Remember, these were put in when they were children. and that we can stent. We end up doing covered stents mostly in these individuals. Moving on to the third case. This is a 38-year-old born in 1984. So what's interesting is these people were born on that brink of where they could have been an arterial switch, but whatever the surgical specialties were at the institution, they got an atrial switch. We found this chart, which we love to see in adult congenital heart disease, is a drawing done by a surgeon at the time when he was 2 years old when he had the surgery. So this was done in 1986. And it shows the pressures of his heart as well as how the baffle is done as a picture that I illustrated at the beginning of this talk. And what I'll say is that if you look here, already at 2 years old, his diastolic pressure in his RV is 15. So I'm going to start on echo with him. He was admitted with SVT and heart failure, was actually in cardiogenic shock on ACE service. We had to start dobutamine because his lactate was high. And you can see as you're looking, massive thrombi in both ventricles. And up to this point in my life, I had seen thrombi in the systemic RV, but not thrombi in both. That means that this guy had very low output for some time. Go to the. I highlight this one to show both the atria and then just to show you how the flow comes in by color flow towards the mitral valve. So this is the systemic venous flow coming in towards the mitral valve. Okay. Escape. All right, so we're going to start with all right, I'm going to start at the top. So once again, the aorta is anterior. This is the PA with the right PA, left PA. This is the aorta. We have a new circle showing up right here. And this is the SVC. So what you see here as you're connecting is that this is the azygos, which is connecting to the SVC, to the atria coming in. When we see that, we have to be very, very concerned that there is complete stenosis or significant stenosis of that SVC baffle, is why that is very important to us. So that's straight off of that image that we suspect. And then I'm going to go to one. This is showing tricuspid regurgitation, systemic RV. Here's your LV. Here's your pulmonary venous baffle. This is your systemic venous baffle, which is right here. You don't see the full extent of it. We take 4-chamber stacked images and you start to see how small this area is. So baffle stenosis is coming into play. And then 31. I put this in. I would call this ventricular septum very straight. This worries me. The RV is kaput. This is probably the lowest RVEF of the 3 patients that I show you today. Here is a nice picture of the tricuspid valve, systemic RV, aortic valve. Here's the tissue nubbin that we talked about earlier. Two great arteries in parallel, with the anterior being more, the aorta being more anterior. And then 124. So the delayed hyperenhancement on this individual was the most pronounced. So I'm going to show you. So here's your short axis. and you have delay hyperenhancement in the anterior wall of the RV all the way through. And you have some here in the inferior wall. And so this gentleman already has now an ICD and a pacemaker, but this increases their risk of ventricular arrhythmias and sudden cardiac death. So on his MRI, there's significant narrowing of the SVC baffle with preferential blood flow going to a very dilated azygos. The IVC baffle narrowed a little bit. I didn't show you the angio on that one, but as it entered the atrium, but not as much as the SVC baffle. The dilated LV, the subpulmonary LVEF was 33%. There was a little delayed hyperenhancement noted at the RV insertion point on the LV side. The RVEF is 17%. RV volumes are enormous. We did this MRI after his echo because we wanted to treat him and then use MRI to see if there were any thrombi. And this individual had no more thrombi. There was also, as I showed you, significant delayed hyperenhancement, and the tricuspid regurgitation by flow calculation was mild. So the pearls for DTGA with atrial switch. First of all, we have MRI protocols built for adults. So our technicians have them built in the machines, which is great. We are looking for baffle stenosis. We're looking for baffle leak. We're looking for systemic RV dysfunction, and we're looking for tricuspid regurgitation. And that's where our focus is on these individuals. So I'm going to end with DTGA, atrial switch, and turn it over to Dr. Fadl, who's going to talk about arterial switch.
Thank you so much, Dr. Shah, for sharing such wonderful review for the atrial switch. I'm sharing my screen. Okay. Now it's my turn to describe the arterial switch operation. This is a surgery that was first successfully performed by Dr. Jatin in 1975. So sometimes it's referred as Jatin's procedure or operation. The whole idea is in patients with TGA, as Dr. Shah mentioned, there is ventricular arterial discordance. So the whole idea is to restore that ventricular arterial concordance by switching the arteries back. This is the main idea. So starting with that, this is there will be some transection of the aorta at the level of the STG and the PA as well, and then switching the arteries back. In that procedure, the pulmonary artery is draped anterior to the aorta to be connected to the right ventricle, what we call the Comte maneuver. So the end result will be the right ventricle connected to the pulmonary artery, so the deoxygenated blood will go to the lungs with the new PA route. With that procedure, we need to do relocation of the coronary arteries from the to the new aorta route, and that would result into some complications sometimes. And now the oxygenated blood goes from the left ventricle to the new aorta route to the aorta to the body. This is the post-contrast T1 cardiac MRI that shows the expected post-surgical appearance, and it's close to the anatomy, the expected anatomy. What we see here is the aortic arch going down with the aorta. You will see the aorta connected to the left ventricle, which is what we expect to see in concordant patients. And the pulmonary artery is draped anterior to the aorta, and like here, and the branch is draping over each side of the ascending aorta, and connect with the PA connected to the right ventricle. So I think with the post-contrast, the hallmark image is this image when you see the pulmonary artery anteriorly and draping of the pulmonary artery branches over the aorta, ascending aorta. Patients with arterial switch procedure has a better long-term outcomes, like 80 to 97% compared to the atrial switch. But you still can come across some complications, including the new aorta dilation. The theory behind it that there is maladaptation of the new aorta root to the systemic pressure, so maybe dilation. This is one of the theories. New aorta regurgitation. With that aortic root new aortic root dilation, you may have some incomplete coaptation of the aortic valve leaflet, new aortic valve leaflets, and regurgitation can happen. Pulmonary artery stenosis, supravalvular, RVOT narrowing, branching stenosis, all can happen, or coronary artery complications. Also, in some patients, as a consequence of these complications, ventricular dysfunction and arrhythmias may happen as well. Starting with the pulmonary artery stenosis, it could be diffuse small pulmonary arteries, or starting from the root, new PA root stenosis, or branching stenosis. The branching stenosis is more common than the supravalvular stenosis. With that Lecomte maneuver and draping of the PA against the new aorta, stretching of the branches of the PA over that aorta may happen, and that will result into some sort of narrowing of the any of the branches. Another possibility for the PA that with the new aorta dilation, it may compress the PA against the sternum, also another possibility of narrowing of the PA. This is an example of an aortic root dilation with a patient with a right PA larger than the left PA on each side of the ascending aorta. Another thing during the procedure itself, the new location of the PA with the rightward deviation of the new PA is usually associated with the stretching of that left PA. It takes longer course to reach the left lung, so it may result into stretching and narrowing. And the left PA is more common to be narrowed when compared to the right PA. And usually the left lung blood flow reduction can happen. And this was correlated in one of the studies with the new aorta root dilation. We call it significant preferential flow when and requires some intervention when the preferential flow is reaching 70 to 30%. But in this patient was less than that, like 60 something and 40%. The other complication that can happen is new aortic root dilation and aortic regurgitation. And significant aortic root dilation, aortic regurgitation can happen after arterial switch, but it is progressively, tend to be progressive over time after surgery, but then it's start to be less progressive during adulthood. In one of the studies that they collected patients from that went into arterial surgery between 1980, I think, till 2000, and they collected like 335 patients, and they found that initially the Z-scores for the new aorta was 2.6. The normal Z-scores ranges from -2 to +2. At 5 years, it was progressive to 3.6 at the mean. At 10 years, it was 4.6, but usually after 10 years, there is no significant change. And they found that the predictors for the aortic root dilation and aortic regurgitation, if the patient had undergone previous pulmonary artery banding, that correlated with the aortic root dilation. And the presence of aortic regurgitation correlated also with the history of pulmonary artery banding, but also if the patient was corrected at older age, more than a year of age, year of life, or the presence of VSD. The other complications include coronary arteries. Coronary artery stenosis, kinking, compression can happen during, since there is lots of maneuver, you are reimplanting the coronaries, there is a new aorta dilation, some compression of the coronaries may happen, acute angulation of the reimplanted coronaries may happen. But the prevalence is lower in adults. The complications are lower in adults. The incidence may reach 0.8% in adults. Coronary CT and cardiac stress perfusion studies play an important role in evaluation of ischemia. Based on the guidelines, the 2020 European guidelines, there is questionable if routine screening is in asymptomatic patients with coronaries is warranted. And the SCMR guidelines and European guidelines 2022, the vasodilator test for perfusion is the initial screening test for ischemia. And usually it's recommended in early life, but usually in adulthood, it depends on the symptoms. Regarding the recommendations for the management of complications, if there is coronary artery stenosis, stenting or surgery, can be indicated in patients with ischemia. The new aortic root surgery can be considered if the new aortic root is more than 55 millimeter. Stenting of the PA branches or management of the PA branch stenosis if there is symptoms or if the diameter is more than 50% narrowing with elevated right ventricular pressures. I'm presenting two cases. This is the first patient. She is a 20-year-old female, DTGA, arterial switch, and presenting with non-sustained VTAC. She was subjected to arterial switch at 3 months old and complicated by coronary osteostenosis. And she was subjected to reimplantation of the coronaries at the age of 10 years. This is her cine images. You will see that it is not like the atrial switch procedure. This is very close to the normal anatomy that we see in every cardiac MRI patients. This is the 4-chamber view. There is a small defect at the interventricular septum, likely a small intramuscular VSD. The function was normal in this patient. The LV function was 56%. The RV function was 57%. On the 3-chamber view, you can see here the also relative normal anatomy. This is the new aortic root. This is which is dilated. There is aortic regurg, and we don't have that conus tissue here. The new aortic root is continuous with the mitral valve. And this is a cine image at the level of the branching of the pulmonary artery. You see here the pulmonary artery draping over the ascending aorta, and during systole and diastole, you see the flow. Flow images and phase contrast images in those patients is very crucial to differentiate if there is preferential flow to one of the pulmonary artery branches. And this is the coronal view showing the dilation of the aortic root along with the branches of the aorta on each side, branches of the pulmonary arteries on each side. In this patient, there was no significant preferential flow. It was 55% of the RPA and 45% of the LPA. But there was aortic root dilation. It measured like 4.5 centimeter. And you see here the central aortic regurgitation because of the lack of the coaptation. And this is the coronal view of the aortic root, and you can see the aortic regurgitation. It was a mild regurgitation, 10 cc with a regurgitant fraction of 6.8%. This is coronary gated sequence of MRA, and it shows the coronary arteries. And I'm scrolling slowly through that, and you can start to see we can start from the left. The left is arising from the anterior facing cusp and reaches its territory to the LAD. And the right coronary cusp arising from the right coronary is arising from the right facing cusp and reaches its territory. But there is another branch arising from the right coronary cusp and courses behind the aorta to reach the left circumflex territory. And this is a retroaortic course of the left circumflex arising from the right facing cusp. This is a variation. Coronary MRIs are really helpful in showing the origins and the proximal segments. CTA can show the entire course as well. These are part of the protocol of the for those patients. Perfusion study was performed to evaluate for ischemia, but it was negative. I switched it back. This is the stress above and this is the rest. And it was negative for perfusion defects. You can see the negative perfusion defects. In summary, for this patient had a dilation of the new aorta, 4.5 centimeter, mild regurgitation of the aorta. It's like 6.8% regurgitant fraction. No preferential flow of the branches of the pulmonary arteries. There is a variation of the coronaries. The left circumflex is arising from the right coronary cusp and with retroaortic course. This is the second patient. She is a 30-year-old female DTGA with arterial switch, but she has got history of augmentation of the RVOT and patch repair of the pulmonary arteries, mainly the main pulmonary artery and left PA. And she was presenting with prenatal evaluation. And starting with the cine images, it's close to the normal. It's normal RV function and diastolic volumes, normal LV function. This is the two-chamber view, and you can see the left atrium and left ventricle contracting nicely. This is close to the three-chamber view, and this is a normal new aorta, and within everything within normal. The aorta, part of the evaluation is the new aorta, and it was within normal range, and there is no regurgitation. And when we come to the RVOT views, you can see that this is a location of the transannular patch that happened before or augmentation of the RVOT. You can see it is dyskinetic during the cycle. And you can see that there is some acceleration of the flow through the pulmonary artery areas. On gradient images, you can notice that there is some waist-like appearance, supravalvular waist-like, and there is a through and through movement through the pulmonary valve. And this was the axial view, and you can see the acceleration of the flow through that waist-like, what we call it supravalvular pulmonary stenosis, and through and through movement through the pulmonary valve, indicating supravalvular pulmonary stenosis here and regurgitation to the RV. This was called moderate supravalvular stenosis. Peak velocity was 2.6 meter per second. And the pulmonary regurgitation was calculated as 35%. And this is the cine image through the branching of the aorta, of the pulmonary artery draping over the aorta, and there was no preferential flow. This is the post-contrast vibe of this patient. It's a good sequence to show the anatomy and everything close to the normal, and this is the waist-like narrowing of the PA. Sure. And it's a good to see the branching of the pulmonary artery, but angio also is very helpful in such situations to give the accurate measurements. And this is the coronary gated sequence MRI, and this patient had a variation. This is the right arising from the right facing cusp or anterior facing cusp, and it's going to its territory. The left, when you track the left from the LAD back to the origin, you can see it's arising as well from the anterior facing cusp. So both coronaries are arising from the same cusp, probably with a different ostia. We don't but the angulation of the left main can lead to some ischemia symptoms if the patient is symptomatic, but this patient was asymptomatic. In summary, for this patient had a normal RV volumes and function despite the presence of the supravalvular PA narrowing. The supravalvular PA narrowing had a velocity of 2.6 meter per second. There was a pulmonary regurgitation estimated like 34%. There was no preferential flows of the pulmonary artery branches. There was a variation of the left coronary arising from the same cusp of the right coronary with acute angulation. And that's it. Thank you so much. And let me know, and Dr. Shah, if there is any questions.
So thank you both for going through that. I mean, I'm always amazed how well you both can take these very complex cases and make them digestible for the crowd that doesn't spend as much time in the congenital space. So thank you for going through that. You know, I think I had a question for Dr. Shah first. You mentioned that you've seen some thrombi, a number of thrombi in a systemic RV, and that's one of the things that always strikes me about a systemic RV is how trabeculated the RV typically is compared to the LV in a normal state. And so, you know, it makes me think of all the controversies in LV non-compaction and what conditions do you tend to see thrombus within the systemic RV, and is there criteria for anticoagulation, or is it an EF criteria, or could you comment on that?
Yeah, what's interesting is, remember, in congenital heart disease, we never have 10,000 patients. We have like 10 that people write about, and that's a good study. But no, we don't have any criteria. I think as many DTGAs as I've seen over the years, this is the first one that I've seen with bilateral, both the RV and the LV thrombus. We see RV. I think it's mostly due to, if I were to tell you, the combination is systemic RV dysfunction with atrial arrhythmias. Because I think the combination of that, you already have a baseline reduced RV-EF because it's a systemic RV. You're somewhere in your 30s and 40s. And then you add an atrial arrhythmia on top of that, and your cardiac output just plummets. So I would say it's the combination of being in atrial arrhythmia for a long period of time, plus that.
Thank you. We're not muted. No, you can.
No.
Yeah.
Okay. Hi, thank you, Dr. Shah and Dr. Fadl, for the great talk. A few questions. My first question is for Dr. Shah. So you showed a case of a superior vena cava stenosis, and you mentioned that these guys need to be stented. My question is that this is something that happened like from very young age to older age. Are they not forming collateral veins, or is it a different mechanism? I believe stent is more for anticipation of if they need a device. But you also mentioned that they are symptomatic from their superior vena cava stenosis. I just wanted to ask, like, do they form collaterals, and does it help alleviate symptoms potentially? And my other question, or maybe you want to talk about that, then I ask you the next question.
Yeah, so the SVC stenosis, I don't think occurs in childhood. It's probably more recent in adulthood. Once again, these are 30s to 40-year-olds, so I don't think that they have this as they're 10 years old and they've had it since they were 10. Do we see collateral flow? Yes, we see collateral flow, but the one I showed you at the end is just the azygos became the pop-off. So I don't see, like some of my other congenital heart disease, we have lots of, venal collaterals like the Fontans and things like that. These, you don't get those kind of collaterals as much for some reason. You get the thing that we talk about is dilated azygos. As for SVC syndrome, they'll be subtle. They'll just have decreased blood return, and they'll be like, I don't feel well. I have more sinus headaches. That's the kind of thing. It isn't the classic all of a sudden, hey, I've developed SVC syndrome that we sometimes see. It's more of a chronic. So I think to answer your question is the collateral flow is generally to the azygos that occurs. And I think this occurs more in adulthood than, younger in life, the obstruction.
Just if I can just second that, great talk, by the way, both of you all. You can always learn so much from folks that are so well versed in it. It was great. I just wanted to second what Sangeeta was saying, Leela, and if you catch up with me later, we had a case where the SVC portion of the baffle was occluded, and just like Sangeeta said, the blood was rerouted via the azygos vein to the IVC, and because of the tremendous increased flow coming up from the inferior baffle, it developed a baffle leak. And there was some debate about whether that would require specific treatment, but it was interesting when Dr. Gertz was able to open up the superior limb of the baffle and reestablish good flow without much obstruction, the baffle leak inferiorly resolved because it no longer was sort of overpressurized. And we have some interesting CT and MR images of that. But anyway, thanks so much.
So my next question is that the cases that Dr. Shah showed, they were older and they had the atrial switch and they were in a worse shape. Obviously, the systemic RV was the RV, which is the systemic ventricle, is huge and there is a lot of pressure. And on the other hand, the cases that Dr. Fadl showed, they were younger. Obviously, they got the arterial switch and they were in much better shape. So about the first group, are they candidates to heart transplant if their systemic ventricle fails, basically, or do we have any data on that?
Yes, they are candidates for heart transplantation. So all of these individuals have been seen by the heart failure group. They're just not sick enough at this point to get a transplant. The first individual I showed, we are actually working on qualifying him for a clip of the tricuspid valve to see if we can improve some of the cardiac output, because it's a systemic tricuspid valve. But yeah, we can transplant them. I think we will be going down those paths. It's just the comorbidities. The second case, because of his substance abuse, will likely not be a candidate. The first guy, we're just waiting. And the last guy that I showed you has been so compliant and amazing that he's done awesome. So he doesn't need a transplant. But yes, all of them will be good transplant candidates.
Thank you. And then I have one question for Dr. Fadl. About the dilatation of aortic root, is it a consequence of aortopathy, some sort of aortopathy they have underlying, or is it a consequence of surgery, the other thing? And then the case that you showed that the left main was coming from the right side, these are implanted, right? These are basically transplanted coronaries. Why did they do that?
Yes. Thank you, Leila, for such nice questions. The first question, the new aorta dilation, there are some theories because it's originally the new pulmonary, it's the pulmonary artery root. It's not originally the aorta. Some theories that it is not, it's maladaptation of that new pulmonary, aorta that was originally pulmonary to the systemic pressure, so it keep on dilation. The other theory that it is have some adhesions around it, so it pulls it, particularly in patients with pulmonary history. In the past, they used to do multiple stages pulmonary artery banding. That the wall of the that new aorta is not well adapted to that lots of pulls and pressures. This is one of the things that can, and at the same time, it pushes the pulmonary artery to the sternum in some patients. This is some of the theories that the wall is not holding well of the new aorta because it was originally a PA, pulmonary artery. The second question, yes, these patients are relocated coronary arteries. Yes, they try to reimplant it so the anatomic location is not sometimes it's not the same that they presented with, depending on the surgery feasibility and how they are able to access it. But there are some variations that they cannot change sometimes. That's what I understand. And sometimes the single coronary origin is one of the difficult to be changed. But it depends also on the surgical access. I don't know, Dr. Shah, if you have any about that.
I can comment on that too, if that's okay.
Yes, please.
Yeah, so you know, the most common coronary arrangement is normal coronary arrangement, but they do have increased incidence of abnormal coronaries. And then as she was saying, that they don't want to put the coronaries under tension, and so it also depends on the original orientation and then how geometrically they can reimplant them. Because if they have to put the coronaries under tension, that can increase the risk of osteostenosis or other obstruction. So it really depends on sort of how the surgeon can place them.
And Leila, thank you, Frank, for such addition. I just want to add one more thing about the first question about the new aorta dilation. Some of those patients have altered geometry of the aortic arch, and one of the theories that it creates some pressure and results into some aorta dilation. That's one of the things I read, but I don't know how it is real.
Thank you very much.
I just had one more quick question. I hope you don't feel bombarded from the conference room over here, but Shaimaa, I was sort of struck by some of the cases you showed where, someone who had a surgery at 2 and 10 years of age, there really wasn't all that much in the way of RV adhesions or I imagine constrictive physiology. Is that sort of a known phenomenon that pediatric surgeries tend to promote better healing and less risk for adhesive disease and constrictive physiology? I imagine that sort of has implications for transplant candidacy down the road.
Well, I didn't see much constriction in those patients. And I see the sternotomy wire still showing the metallic artifact, but one surgery during infancy, even before 1 year old. Frank or Dr. Shah, do you have any input about that?
Yeah, I think I'd like to hear from Frank. What's interesting is as many cardiac surgeries as our patients have, pericardial constriction is not a prominent diagnosis we make.
Yeah, that's true. I mean, we see adhesions sometimes, but it's not something that we commonly see, at least during childhood and adolescence. So that's, but I don't have any data to say compare that to what happens with other adult cardiac surgery, non-congenital surgeries.
Yeah, I think that's very interesting, Corey, as a question, because CABG, we see it, and congenital heart disease. I can't think of the last time I saw the pericardium light up.
Yeah, it's interesting.
Mm-hmm.
With the exception of, we do see so in the acute phase, we'll see like post-pericardomy syndrome. So usually like, 2 to 8 weeks after surgery. And so we can see it there, but I don't really see a lot of it late.
Right. Well, thank you both again for a really wonderful session, and everybody who contributed to the discussion. This is really great. And we'll see everybody back next week.
Thank you.
Thank you.